Okay. Hello. Yeah. Hi, welcome everybody. Okay. Not open? It is open, okay. Yeah. Please take your seats. Yeah. Thank you for the applause, but we haven't actually said anything yet. But okay, welcome everybody to the session on pathways to better care, best practice examples from across Europe. We're very lucky to have with us two highly experienced people involved in policy advocacy and campaigning. Lisa Murray from the UK and Jean-Michel Fourier from France. They're each going to talk to us about something, a situation in their own countries, from which we will then be able to ask questions and explore what it means for all the other countries that we have represented in the room. We're going to kick off, each person is going to talk for about 15 minutes to give us 20 minutes for Q&A at the end. And if I keep doing this, I apologize, but it's impossible to see anybody under these lights. First of all, over to Jean-Michel. Jean-Michel was a colleague of mine on the board of EUPFF for many years. He's an IPF patient since 2017 and president of the French Patient Organization, which he has actually, he wouldn't say so himself, but he's transformed over the last 4 or 5 years, which was very good to see, going from strength to strength. He told me the other day that he recently, he's a living exemplar of the value of exercise when you're suffering from pulmonary fibrosis. I mean, I've always been amazed. He's done these fabulous short takes of him walking on the beach near where he lives in Bordeaux and stuff. But now recently he started competitive walking, 8 years into IPF, and he won a race the other day. I think it must have been for people of a certain age group, but he didn't. Sorry, he's younger than me, but he did it 9 kilometers in 2 hours. Now, hands up in the room, anybody else who could do 9 kilometers in 2 hours? Okay, Lisa, yeah. So anyway, Jean-Michel, thank you very much to talk about the Right to Breathe collective in France. So over to you.
Thank you, Steve, and good morning, everyone. It's a challenge for me to talk in English, so I will try to keep your attention, but my excuse for my English. So I am today with my hat not as a patient, but as a patient representative to talk to you about the Right to Breathe collective, which is a French national coalition dedicated to respiratory health. So what is it? The Right to Breathe collective was created in 2021 and structured in 2024. Today it brings together 28 organizations. The interesting point is that we have patients' organizations, so from the full range of respiratory diseases, from asthma, allergy, lung cancer, to rare diseases patients' organization. We have also healthcare organization, for example, the French Respiratory Societies, French Federation of Pulmonologists. We are all together in this coalition, and civil society groups. We operate as a non-profit organization with 3 main missions. The first one is to mobilize all stakeholders around respiratory health. Our second mission is to advocate for stronger public policies. And the third one is to structure public debate about it. And we are organizing a public event each year about respiratory diseases. So in short, in fact, our goal is to build a collective and ambitious vision for respiratory health in France. So we have one pillar we started at the beginning. it's a reference. Don't look at no. Don't look necessarily at the detail, but it's a reference monitoring tool we launched in 2023 at the French National Assembly. Its purpose is really to monitor and to assess, to rate public policies in respiratory health and on a yearly basis. So it is a structure around 6 main pillars, which are trying to cover the full scope of respiratory diseases. We are talking, the first one is prevention, the second one is diagnosis, third one, care pathways, fourth one, innovation, then inclusion and awareness about respiratory diseases. As this is for us essential because it is really the ground of our discussions. Data is key. So we need that to identify gaps and to track progress over time around these 6 pillars. So if here an example, don't look at the data, but it is how it is shown each year on our site. So we have as you can see, indicators showing what is our rating about the public policy in France around these 6 topics. And for each indicator, we are publishing a 1-page summary about the situation, what is going right from our view, and what is going wrong. So why a national respiratory health plan? In France, we are more than 10 million people suffering from a respiratory disease. It is around 15% of the population. This represents a major public health challenge with high mortality and a growing economic burden for the country. So despite this, we assess that the public policy are still fragmented, not coordinated, and lacking, as often, a long-term vision. So we recently, in 2024, the French Court of Auditors highlighted that in a report. Main outcome was that there is a sharp increase in healthcare expenditure and hospitalization in France in the domain of respiratory. And they conclude that there is an urgent need for a structured national plan. So this is in this context that we decided to act and to develop a national respiratory health plan, which is a multi-year plan from 2026 to 2030. Built on clear strategic objectives and robust indicators, as we are doing with our observatory. It covers the full scope of respiratory health. We are talking about prevention, we are talking about risk reduction, we are talking about improving care pathways from young age, from early age to old age, and with a strong focus on prevention in everyday environment. I mean schools, workplaces, home, healthcare facilities too. We are talking about early detection. We are talking about also, it's an important point about recognition of respiratory disability, which is not fully the case today in France. So our methodology was really based on two key principles: evidence-based and collaborative work. So we use multiple sources, the observatory I mentioned previously, but also the public reports, some European benchmarks, and for me, maybe the most important, continuous stakeholders discussion, and with feedback every time we want to add something or to propose something. And we followed, with all this material, a clear process to identify gaps in our public health in France, to translate them into concrete actions, and to align with political and operational realities. Important for me, and again, the entire process was built together. Patients, organization, and healthcare professional organization. We want to talk one voice to the authorities. So don't look at the details. So the result is that it's always under process. We will propose 17 measures, 17 important measures in our plan on how can I say that? Organized with four main domains. The first one will be prevention and early detection. We will talk about tobacco, for example, about tobacco control, about air quality improvement. We'll talk about early screening. Second pillar will be care pathways. We will talk about better coordination between multidisciplines. We will talk about building on digital solutions. We will talk about local territorial initiatives all around our country. Third pillar will be quality of life and disability. And again, we need disability. Respiratory disability is not recognized in France for the moment. So we want to get it recognized. We want to improve access to rights for patients, which is so difficult at that time. And we will look at all inequalities all around the country, all around the culture, to be sure that to try to reduce these inequalities. And a fourth pillar, which is governance. We are asking for a clear national strategy led by the government and across ministries. We need to get health ministry. We need to get environment ministry. We need to get education ministry. We need to get that coordinated at the government level. And we also will ask for a structured implementation and a strong territorial deployment. So, to conclude, our ambition is really now to position this respiratory health plan as a national priority. We will integrate this plan into, if you don't know, we will have a presidential cycle in 2027 in France. So it's key for us to get it in this discussion, in this cycle for presidential. And then, as a collective, we want to support its implementation. So we are now entering in this difficult phase to discuss and to engage with politics and policymakers. So what we have learned, the importance of data. Talking to these people, you need evidence, you need facts, you need data. Conviction is not enough. Second point is the system approach, which is critical to always have in mind prevention, care, and environment, all that integrated. Timing matters. There are some political momentum and policy windows. You have to be focused on that and try to use these political windows when it happens. Coalitions amplify influence. So with a collective voice, all patients' organizations, all professional organizations together, we have a stronger legitimacy to make it. And then political needs, in fact, they need solution. If you are explaining to them what are the gaps, it's not enough. You need to deliver them the solutions. This is a great learning for us. And personally, I have learned that you need to be patient, not as a patient, but patient with politics. They are experts in discussions. They always say yes when you are explaining the situation to them. They are less efficient when talking about actions, and sometimes they disappear at this time. So you have to be patient and repeat and repeat and repeat. And maybe one day you will have to repeat again. but it's really my learning. So it takes time to move to move to action. It takes a lot of time. And my second learning personally is that our small, rare diseases organization are often the more responsive and the more dynamic. So don't be shy. As Pulmonary Fibrosis Association, take the lead. Take the lead. I am now co-president of the collective. I never asked for that. All the 28 organizations asked me to be the co-president of the collective. Don't be shy. Take the lead. Take the power about it. And if I have one message to leave to you today, it is this one. If it is not yet the case, join your national coalition. I was talking about the French one. There is today 21 national coalition in France, and we are grouped in what we call the International Respiratory Coalition. So join it. Join it to ensure that PF, pulmonary fibrosis, is included in their discussion, and that they will not fight only about COPD, about asthma, about cancer. We are there as patients, so join it. And you will also benefit from all this joint effort, we all together, and energy. So thank you for your attention.
Thank you very much indeed, Jean-Michel. If you come and join us here again, we'll take questions afterwards, yeah? Okay, great. Over to you, Lisa. And Lisa is going to talk to us about transforming the ILD service in the UK. Yeah. Thank you very much, Jean-Michel.
Hello everybody, this is my first EUPFF, so I'm very excited to be here and as a speaker and sharing the stage with two fantastic gentlemen. I'm from Action for Pulmonary Fibrosis, which is a UK-based charity, so I will be focusing today on our work that we've done in the care pathway, specifically in the National Health System in England. But I do want to just start off by saying, as we've spoken earlier, the principles that guided our approach are universal. So it doesn't really matter what health system that you're working in, what funding streams that you're working with. This is really a framework that can be applied anywhere. Because at its core, meaningful improvement comes from focusing on changes that create and align with true needs, and really that's what matters. So hopefully some of the following will resonate with some of you, and I've got a lot of ground to cover, so I better get on with it. I'm going to start off with this message from Suzanne, who is one of our lived experience panel members, so she works very closely with us. And this is her experience having lost her father to PF in 2023. The experience of herself, her family, and her father was a terrible one. They felt that failures in his care had led to him being taken from them too early. And this is a horrendous situation that nobody should go through. But unfortunately, that's not a unique situation in the UK. And from yesterday, I understand now that it's likely not uncommon in your own countries either. And it's stories like this that made APF step forwards into an influencing role, not just a supportive one, and to be ambitious with what we want to achieve in the coming years. But it's also working with people like Suzanne who give us their time, their energy and their emotional strength to provide lived experience to our influencing work that give it all the much more power, which was been mentioned today already this morning as well. So for context, we are an international audience. The care in NHS England is broken up mostly into sort of 3 levels. So we start off in primary care, which is the local doctor of any very generalist medicine. And you go up the pyramid depending on how complex your needs are. So around 73% of PF patients in the UK report their symptoms to a GP or local doctor first, and then will make their way up the pyramid here. So urgent and secondary care is your general hospitals where there's other diagnostic tests such as x-rays, CTs and things like that that aren't available in primary care. But PF care actually sits within wider interstitial lung disease services within specialist care, and it's classed as specialist care because it is complex and expensive to treat. But for context as well, there are around 200 hospitals, general hospitals in England, but there's only 24 centres that provide PF and ILD care. And at APF, we provide support to anyone affected by PF, regardless of where they are in this care pathway, moving upwards. So just bear that in mind when I use some terminology. So that in itself creates some difficulties. And like many health systems across the world, the NHS is struggling a little bit. We have workforce shortages, we've got limited budgets, we've got a lot of policy changes that we're working within, and all of this is particularly felt within PS services because demand is rising much quicker than the system can adapt to keep up. So this results in high unmet need and inequality within PF care and for PF patients. So despite diagnostics and research moving forwards, we're still having delays, misdiagnoses and late treatment. And the impact that this has on PF patients is massive. We know this because as a support charity, we hear firsthand from people that are experiencing PF care. We're told about the challenges that they face within a system when they're already experiencing such a difficult journey. We decided in 2023, to collect this information more formally. So we conducted what was at the time the UK's biggest PF lived experience survey. And what patients and carers told us was that they were facing inequalities in care based on where they lived, that they were facing a lack of support and a complete lack of information, and actually that with what little they receive in terms of care and support, they wish they had cancer because cancer care is so much better. So these answers really said to us that the people that we were supporting needed more and that urgent action was needed to address these huge issues. And I'm preaching to the choir here because we've already heard quite a lot this morning about how important it is to bring stakeholders together and how bringing together experts from all across the community increases credibility and power to what you are shouting for. And so we discovered the same thing. After the findings of this report, we put together One Voice ILD, which brings together stakeholders from all across the community to shout together for change with one voice. And at the heart of the One Voice ILD movement is the lived experience panel again, making sure that those with lived experience are at the heart of all of our decision making, our discussions, and the activities that come out of One Voice ILD, and make sure that they bring urgency and reality to what we're shouting for and what actions we decide to do. Oh, yes, sorry, I forgot about this bit. So this is something that we bring across all of our work as a charity as well. So we now have an involvement network of around 200 people that are patients, carers, people with lived experience, those that are bereaved, that feed into all aspects of APF and are guided by a dedicated member of staff who is our involvement network lead. And so we make sure that the patient voice is included, not just included, sorry, but central to everything that we do. And as part of this, the survey was what started the development of the care pathway. It was actually over 1,200 people that contributed to it, that became the basis of what was developed. And I need to thank Anne-Marie Russell, who presented there she is, hi, the care pathway yesterday, which you would have seen was a very technical, complicated document that this is just the front page of. I'm not going to go into the technical side of it, so thank you for doing that. That became recommendations for what we needed to make care better in England. So it was based on lived experience. Lived experience was involved throughout the development of it with the One Voice ILD steering group and panel, which some of the members of are in the room today. And then we also needed to make sure that although we were being ambitious with what we wanted to achieve, that the recommendations that we're making were also clinically appropriate and safe. So we had over 80 professional responses through a Delphi study that made sure that that was the case for what was recommended. So I'm not going to take you through the actual care pathway, but what I'm going to do is give you an example of what this means in reality for the average patient journey. So the average patient, in this case, she is named Mary, has a cough and some breathlessness that she starts experiencing. After 3 months, nothing's getting better, so she decides to go to her GP, her local doctor. But there she's misdiagnosed. Oh, that's very small. I'm sorry, it wasn't that small in my, my initial PowerPoint. But she's repeatedly treated for an infection that she doesn't have. And after 6 months, she finally gets to reach her general hospital for tests, further testing, further investigation. She can't be diagnosed at a secondary hospital in the model of care that we currently have, so she has to be referred to a specialist centre, and she waits another 6 months to get to there. By that time, her tests are out of date and they need redone. And by the time that she's actually diagnosed, 21 months have passed. And for some people, this completely misses the window of opportunity for treatment and is just a series, not one mistake, but a series of delays that lead up to real life, terrible circumstances. So what we did was look at this model and what needed to actually change, what key principles that were needed to change to make the actual experience of PF patients in the UK better. So for us, this was having diagnostic tests available locally and in primary care, so that people could start the diagnosis process closer to home and sooner. We can't have massive delays before people even start to begin looking into what's wrong. To bring specialist care also closer to home, make it more accessible and equitably accessible no matter where you are in any region because of the location-based inequalities that were mentioned earlier. And also to make sure that supportive services are available throughout that care pathway across all levels of care, because people don't start becoming to feel ill once they're diagnosed. That's something that they need throughout the journey. And what the pathway looks at now, based on these principles, we can overcome a lot of these delays. So in the care pathway theoretical that Anne-Marie shared, what we're looking at now is bringing these diagnostic tests locally, having them referrals made as standard for those that appear with classic symptoms. And they can have diagnostic tests like spirometry before they're ever referred to a general hospital. And the beauty of a care pathway like this is that somebody like Mary never has to step foot in a specialist centre that can be hundreds of miles away, because her consultant can present her case within a virtual regional meeting that happens every few weeks, and the decision to be her diagnosis and the decision to start treatment can be made in collaboration with specialist doctors, and made straight away. And in this situation, we're cutting out all those long waits for appointments, the long travel times which are difficult for patients, and creating a situation where she could be diagnosed and start treatment much earlier, giving her the best possible situation for longer, living better for longer. And you might think, well, that's just England, but actually what matters here isn't the structure of the health system, it's the principles underlying what activities we chose to take part in. And it's not in theory anymore. We've been working really closely with 2 areas of England over the past year to pilot some of the recommendations that were made in the Care Pathway Report. So part of that has been the virtual regional network, and then part of it has also been looking at referral processes and efficiencies within the system. In the east of England, 3 in 10 patients seen in the past year have not needed to visit a specialist centre, have removed the need for travelling, and had their care managed locally. And in Greater Manchester, waits to see specialists have been reduced from a massive 42 weeks to just 10. So this is real life changing people's access to treatment earlier, and making that whole process so much better with a reduction in uncertainty, that time that illness can progress while it's being unmonitored, unchecked. And yeah, we're doing this already, and internationally, sort of, within the UK. So how PF care is provided is not in that same pyramid across UK countries. It's provided very different in the developed nations. And we're using those same principles, that same approach with partners in each of the devolved nations to develop solutions that are based on true needs within their local areas, and also fit with their systems, and meet true needs. Again, based on lived experience. And a huge part of that is agreeing what data should be put into and coming out of the system, and having the underlying agreement that everyone, no matter where they are, should be able to have specialist advice at the right time, close to home, no matter where they are. There we are. So again, as well as an enabler, one of our biggest challenges is data. We don't have a national picture of what PF looks like in terms of experiences, and that is something that we do need to have across all of the UK and all of our work. So again, we tried to address that, and we stepped forward by undertaking another large survey, which we overtook ourselves as the biggest PF lived experience survey ever conducted in the UK. And a few weeks ago, we published our Pulmonary Fibrosis State of the Nation report. I'm not going to go too far into this because it's in a poster next door. So if you want to go and have a look at some of the key findings, please do, or come and speak to us. Some of the findings that we had from that were really horrendous. 34% of people waited over a year for a confirmed diagnosis, and I know from the presentations and discussions we've had that that's even worse in some of your countries. That having this information is key because it helps us go from a joint goal to concrete action, because it highlights where the gaps are and where resources should be focused. And that's really something that you need when you're working in a competitive environment, politically, and also in such an underrepresented disease type. And it's working with people like Dave, who's living with IPF, that again makes sure that that data never becomes abstract. It brings us back into what that means for people in real life, and that's such a powerful thing, as we said at the start, when it comes to advocacy and influencing. So I'm just going to, I've already had my red flag, so I'm just going to close by going back to Suzanne's reminder that PF care and failures in PF care cannot continue. We fully agree. We've made a good start at trying to tackle that within the UK, and we're more dedicated than ever to make sure that that happens. And if you are considering doing something like that in your own country as well, please come and speak to us. We can share our our experience in it, our principles, and support you however we can. And if you are preferring not to come and speak to us this weekend, you can visit our resources on our website as well. Thank you very much.
Great. Thank you very much indeed, Lisa. That was great. I mean, I think for both of you, there's a sense of, in both cases, being opportunistic. In when you're looking on policy and campaign, being ready, because I know from my own involvement with Action for Pulmonary Fibrosis that the One Voice ILD, this bringing together of all of the hospitals in the country to come up with a cared pathway with a very strong patient input, as Lisa explained, that was only possible because of 6 or 7 years of the charity working with all the leading doctors in the country, building up that trust. And then there came a moment when it was right. And in fact, Action for Pulmonary Fibrosis came in and were asked, in a sense, to facilitate this process. So, I mean, quite astounding. And what you've done, I think, is absolutely amazing. And it will have really big impact on patients' lives, we think. And similarly with you, Jean-Michel, you were talking about the presidential cycle, the need to be ready for it. I don't know how you work with 28 organizations from across things, which is another question somebody might like to ask. Anyway, sorry, I'm rabbiting on. Let's have a question from the floor. Yeah, please. One down here, please. Could you bring a microphone down here, please? Thank you.
Thank you, Lisa, for the clear presentation. I paid clear attention to the action that you want to prioritize, and in particular to the diagnostic tools locally implemented, which is a great advantage for patients, of course. You don't have to move the patients to the hub, you don't move the patient to the academic center, so you can prepare a chart of the patients and to recommend to the expert what is the suspicion. But on the other side, what kind of diagnostic tool you are referring to? Because sometimes we have dealing with a lot of problems, for example, also with blood testing regarding connective tissue disease, interstitial disease associated. So in terms of priority, would you mean diagnostic tools with invasive procedure, or do you mean diagnostic tool with non-invasive procedure like blood test, which is also a great deal for example, for rheumatology diseases?
Yeah, is this working? Yeah, that's a great question. Obviously not all diagnostic tests can be made, and for us it's primary care level, is mostly what we refer to as local. Spirometry is really the main one, and it used to be available within GPs locally across the UK, and it was actually scaled back because it was deemed not cost effective. But actually, with the high rate of misdiagnoses, that I think that in itself shows that if you do that initially, you're cutting out a huge part of a care pathway that they don't need to be going down. A third of our patients are misdiagnosed, and 73% of those that are start a treatment that they don't need to be on. So in terms of cost effectiveness, that's one thing, but that's not really your question. So something like spirometry to happen first. Something like a HRCT still needs to happen at a hospital because that's not available within primary care, but that can happen with a spirometry result before the appointment actually happens. Blood testing and monitoring is something that we're still doing within hospital settings mostly as well. But one of the big problems that we have in having that is that everybody's on a different online system in the UK. Even within one site to another, their systems don't speak to each other. So it's actually even having that set up so that blood monitoring and testing can be done, and especially if they're on antifibrotics within a hospital setting that's not a specialist centre. So no, you make a very good point. Some of it can be brought down, but again, yeah, not all diagnostic tests. I'm not sure if that answers your question.
Thank you. I think the key one is the CT scan on that, which is to get a CT scan done locally, if it can be done. Yeah. It will be much quicker. Then the person can be directly sent to the ILD centre,
Yeah.
rather than going through the general hospital, which can save a matter of months
Yeah.
in waiting time. I mean, at the moment, it's taking over a year to diagnose patients in many parts of the UK. I mean, when you've got a 3 to 5 year life expectancy, it's terrible. There's one down here, please. Yeah.
Yes. Thank you very much for your presentation. It was very interesting. And from yesterday and today, we are hearing all, and we know all of us who are in this room, that holistic approach in our disease and in rare disease is the key to have a better life. There is not only medicines, but we have to big support from other specialists. And I am wondering, connecting this with the previous session, that we are going to policymakers. If we are going to call policymakers, they want for us to talk with numbers. How much it costs this versus have an holistic approach or non-holistic approach. So I'm thinking, and I'm asking your opinion, what we could do in order to have these elements in order to address to policymakers and tell them that is the facts that we want, and we are a community with no very much people. And the registry, what was referred before, is very, very significant for us. I think that as AUPFF and as association, we have a lot of work to do in a specific direction. And I'd like to have your opinion about this thought. Thank you very much.
Yeah, just maybe an element of thinking, Eleni. You are right. Politics want figures and data. What's shown, for example, the report I mentioned about respiratory health in France was showing a huge increase on cost due to hospitalizations and passage to emergency and so on. And so it was also shown that with an amount of money for prevention, this could reduce drastically this cost, because we will decrease the number of hospitalizations for respiratory health. So this is exactly the kind of things we need to show to the politics. So you will find studies about that, and the difficulty is to collect the figures and to be able to present it, to show that with expenses you can save money. The problem, so you will not solve everything with that, because the problem is that guys think short term.
Yes.
And it's always a discussion, and we need, and it's why we try to build a multi-year plan, is really to show to them that you will need to spend money for prevention, for some really practical things on field on the territory, to save money maybe 2 years, 3 years, 4 years, 5 years, 10 years later. So this is the main difficulty from my point of view. But looking at what is happening in our countries, you can find figures. And if you don't, you can be helped for that. And you are right, Eleni. Figures and data are key. When I tried the first time to discuss with a member of parliament only with conviction, he was saying yes, 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 but nothing more after. You need to talk about money and economic. It's a pity, but it is like that.
Thanks, Lisa.
Yeah, no, I fully agree. I had a little bit of a discussion about that yesterday, actually, when we were talking about pulmonary rehabilitation in one of the workshops, and the fact that the research is out there to prove that going to pulmonary rehab actually reduces urgent care admissions and hospital admissions, and the use of ILD nurse time and things like that in the UK. Using data like that already exists to frame that in an economic way. We don't do that with an APF either. I don't have the expertise to do the health economic costing, but it is out there in ways that you can frame to say this is money saving in the long term. We are working with some corporate and pharma partners just now to cost the care pathway, to be able to show actually doing it this way costs this amount compared to how you were doing it before. And again, if that data is out there for another country, it's applicable. So if it's out there, use it. We certainly have a plan to have that made available that maybe would be of use to you as well if you're trying to apply for that.
Thank you very much.
Yeah, it's great.
Yes.
Thank you very much.
Just a quick comment on Jean-Michel's point about the International Respiratory Coalition. I think they actually publish a lot of data on ILDs, the daily cost, and facts and figures around health economics. But my main question was really to Lisa, like the commissioners were in the room as part of One ILD. Was that because they saw that there might be an economic saving by taking part, or how did you get them in the room, basically?
Oh, the first one was before my time, so that's a great question. I'm maybe not the fullest answer, but at this point in time, we're still working with the commissioners. We still have them within discussions. We have meetings, and also when it comes to the ILD clinical networks, they are being able to get ICB leads and commissioners at those meetings as well, and it is a key part of it. You need to have them on board to be able to move everything forward, and I guess that is the part of it that we have this data that shows bad things are happening, and aligning it with the fact that something Jean-Michel mentioned that I mentioned to you earlier was that broader political and health system plans are exactly in line with what we're trying to do as well. We've aligned these, what we're suggesting, these principles with the fact that they are trying to move care closer to home. They are trying to avoid misdiagnoses and things like that. And this is a sort of a solution to offer to them. It's something to say, this will help you do your job and do it better and take some of that pressure off of you. So I definitely think that's been part of getting buy-in from commissioners to that this is a benefit for them as well as for patients and carers.
So that's again being opportunistic in a sense.
Yeah, absolutely.
The political situation changes.
Yeah.
Because I mean, I don't know, Jean-Michel, how much of what you've been talking about was done in close collaboration with the French government and the French health services? Were you working with them at all, or was this outside? You see, the difference is when, I believe, I was there at the very beginning of, the One Voice ILD, and what happened was that the NHS said, well, it's a very nice idea, the National Health Service, but we won't, just because you're going to do this doesn't mean we're going to accept it. But what happened was there was suddenly a change of personnel, and the person who became the respiratory, the top guy for the UK on respiratory, suddenly became he wasn't actually an ILD doctor, but he was very supportive. And so he pushed it, and suddenly we found a lot of cooperation, and now, although the care pathway, the one that Anne-Marie showed yesterday, isn't actually an NHS stamped and accepted document.
Yet.
It's highly, but it's highly influential. So I think that was a case where we were lucky. The NHS was kind of open to the ideas, and we were doing...
That's the thing, they're struggling. They need ideas.
They need ideas.
And they need ways to address inefficiencies, and that as well is something it does. It avoids repeat testing, it avoids long waits that lead to emergency admissions, etc. So it's about addressing inefficiencies and inequalities as much as anything else.
Yeah, thanks Lisa.
In France, for example, Steve, we got 8 health ministers the last 2 years.
8?
Yeah.
Wow.
Not bad.
Yeah. It is changing maybe more than in Belgium.
we have that many prime ministers.
So it is not helping. This is my first my first answer. I would like to highlight something also. For us as pulmonary fibrosis patients organizations, we are small. We are very often only volunteers. So if we want to go to see the health minister, we have a few chances to succeed. So it's the reason why we need to get coalition every time we can. There is different ways. We were speaking this morning about rare diseases coalition. This is one way to address our needs. You have also national coalitions, that example I was presenting in France, but don't forget also our federation. And again, I think it is the role of the federation to push that kind of needs, to maybe help to get figures, things like that, to be able to be more to be more efficient when discussing with the authorities. I can tell you the first time we went to health ministry in France to talk about our collective, they were surprised because they were not attending to see together one professional representative and one patient representative telling together, this is what you need to do to move. And they were really surprised about it. So I want really to highlight that. Coalitions, but never forget to, when you want to go to the authorities, you have very much more power when you go patient and professionals together.
Yeah, very much. Another question over there, please. I think it's Claudio. Yeah. Mike, have a mic first. Hang on. Yeah. Oh, I'm sorry. Sorry, Claudio, wait a second. Sorry, there's one over here. I couldn't see it back. We'll come to you next, Claudio. Yeah? Yeah.
Shall I go? Or?
Yeah.
Yeah. Yeah. It's just
Hi, Anne-Marie, sorry.
No, that's fine. It's difficult to see, I appreciate. It's just a quick point, really, going back to diagnostics, because I think for everybody, securing a diagnosis, even if that is diagnostic uncertainty and it's not a known definitive interstitial lung disease, is an important step in accessing the rest of the pathway. And I'm sorry that I'm speaking to the UK example, but that's what I'm familiar with. But I wonder what we might learn from that early diagnosis in different European countries too. Is the general practice model is definitely struggling at the moment. Yeah. And I think it was correct that spirometry was removed from the GP office because of quality control issues. And we do now have centres that provide spirometry. But that is just one component. So spirometry is really looking at forced vital capacity, FEV1, and the ratio. And sometimes that can come back as appearing normal when one doesn't have a baseline spirometry for a patient. So I think the message is spirometry can add, but sometimes it can detract. And we really need the transfer factor. We need the DLCO to help with those diagnostics in stimulating the step onto the next pathway. And we mentioned a little bit about the breathlessness pathway. Yes. And again, I think that that's really important because it can trigger patients to have cardiac causes removed, but then assist with onward referral. So I feel there's still quite a little bit of work to do around that primary care setting. Yeah. And perhaps where the advocacy agencies have a really strong position is on the public health campaigning. Yeah. Yeah. We have the lung cancer screening, but only a small percentage of patients from that lung cancer screening program are identified as having an interstitial lung abnormality. And again, about 2% of those patients go on to have a diagnosis with ILD. So maybe some public health campaigning around not so much the cough that's triggered the lung cancer screening, but around symptom recognition and around that breathlessness and the importance of accessing a breathlessness pathway could help.
Great. Thanks, Anne-Marie. Do you want to go?
Yeah, please. Yeah, fantastic point. So the breathlessness pathway, yeah, absolutely is really important in this and gets people on the right investigative track earlier on. What So for those that don't know, this is a sort of guideline that exists in NHS England only, that for those that present with breathlessness gets sent for tests as standard. But we had to look at that actually in our State of the Nation survey, just in terms of a comparison between referral speed and after repeated presentations to a GP across the devolved nations. And actually, despite that policy piece being in place in England, they are not referring quicker or with singular presentations. People are having to go to their GP 4 or 5 times before they are being referred for any kind of tests. So the breathlessness pathway is fantastic in theory, but I think the key point there as well is that more needs to be done to implement it locally so that places are actually using it, because it appears at the moment that it's actually not really being used, and that's another piece of work that needs to be done alongside implementing the care pathway as a wider piece, for sure, yeah.
Thanks, Lisa. Jean-Michel.
Yes, Anne-Marie, just thank you for your question. We have a brilliant session this afternoon at 4:45 about early diagnosis and prevention, so you can keep it also
We'll
for
judge
this afternoon.
Great, thank you. Claudio, please. We only have a minute,
Yes.
1 minute left here.
One of my questions have been already answered partially. So I was just wondering and asking how diffuse it is, the spirometry in terms of complexity like the LCO, and if you have cutting-edge technology for CT scans in your UK system to make a broader and more valid diagnosis of the disease. And plus, 2 more questions very quickly. How is the state of advancement of the filling out of the registries in France, for example, in the UK? And how much the clinical trials are now around in your national systems, both UK and France, for example? Thank you.
Fine, thank you, Claudia. I'm very sorry. Questions 1 and 3 we'll talk to over coffee. And question 2 about registries, Jean-Michel. You don't know how well the registries are doing in France, no?
Yeah, we have it. So the British Thoracic Society have a registry that was previously just IPF, and now they've opened it up from, I think, February to wider ILDs. So initially, it wasn't capturing any data of other progressive pulmonary fibroses, and we should get a better picture of that now. Good data came out of it, but it's not comprehensive. It's also only mandatory for specialist centres, so that top tier of care, to register their patients, but there's not a means to hold them to account to do that, and they also don't have time. It takes an awful lot of time to get consent for a patient to put their information into it and to fill it out. And one of the big issues that we have in the NHS widely is a lack of administrative support. And so the registry would be great if we had the resources to actually be using it. But I think it's definitely improving with awareness that we need that data. And also we're pushing for an audit as well as having a registry.
Well, thank you very much indeed. One question we didn't get to is one of evidence, and I think we maybe need a session on evidence at our next summit, because the arguments we make, the data we give, linked to what Jean-Michel was saying about the financial and the economic case, we need to get much better at that than we are. The cardiology has this sussed. They can make their arguments extremely well. We find it much more difficult. So maybe next time. But Lisa, Jean-Michel, thank you very much indeed for 2 really great presentations. Thank you.